This meeting to order. I'll call the Health Insurance Reform Commission to order. And the first order of business is nominating of officers. Oh, we have to start with roll call. I apologize.
Delegate Sullivan, Delegate McNamara, here. Delegate Helmer, here. Delegate Maldonado,
here.
Delegate Hayes, Senator Deeds,
Present.
Senator DeSteff, here. Senator McPike, Senator Bagby, present. Senator Surville,
here.
Secretary Kelly, Commissioner White. We have a quorum.
Okay. Well, we can do introductions, and then I guess we'll have elections. Lamont, do you want to start by telling people who you are?
I'm Lamont.
Senator
Lamont Bagby, representing the 14th District, Eastern Henrico, most of Richmond.
Delegate Cliff Hayes, representing the 91st District, the northern end of Chesapeake, and a small portion of Portsmouth.
Delegate Dan Helmer, representing the 10th District, much of southwest Fairfax County.
Good morning. I'm Joe McNamara. I represent delegate from Salem, part of Roanoke County, part of Roanoke City.
Good morning. I'm Delegate Michelle Lopes Maldonado, and I represent District 50 in Northern Virginia, which includes the cities of Manassas Park, Manassas, and portions of the western end of Prince William.
I'm Creed Deeds from Senate District 11 to represent Charlottesville, Albemarle, Nelson, Amherst, and part of Louisa.
I'm Scott Surville, State Senator for the 34th Senate District, which is basically eastern Fairfax County. I'm also only one of two remaining, two members willing to return to this commission from before.
Not sure what that says. Senator Bill DeSteff, Virginia Beach, Norfolk, and 42 towns and counties and cities.
Good morning, everyone. I'm Jonah Roca, Assistant Secretary in the Office of Health and Human Resources. I'm here to represent Secretary Kelly.
Welcome. Okay, welcome everybody. First, the next order of business is election of officers. We need to elect a chair. And I'm not the chair. I'll make a motion that Delegate Rip Sullivan be elected chair.
Second.
Are there further nominations? Okay, all in favor of Rip Sullivan, say aye.
Aye.
Opposed? Okay, all nominations for vice chair are in order.
I move Senator Creed Deeds to be vice chair.
Second.
Are there further nominations? All in favor of me being vice chair?
Aye.
Aye. All opposed? Okay, 1-0. Okay. In the absence of the chair, I will. First thing on the agenda is the adoption of electronic meeting policy. Tom, I think you've got that, and it's in your packet. Maybe you want to explain what we've got in front of us.
Yes, sir. Under FOIA Section 2.2-3708.3, it requires public bodies adopt a participation policy before having remote participation or all virtual meetings. The policy before you would allow remote participation in all virtual meetings to the full extent under the statute, with two exceptions. One, it would not allow a member living more than 60 miles away to attend remotely for that reason, and it also would not allow members participating remotely to make motions or to vote. You all could adopt this policy. You could certainly adopt a policy that was the full extent under 3708.3, or you could narrow this further.
Tom, is this similar to what other commissions have adopted?
Yes, sir. This is consistent with what some other commissions have adopted.
Does anyone on the commission have a question for Tom, or any comment they want to make? If not, is there a motion to adopt this policy?
Move adoption. Second.
A motion and a second to adopt this is our remote access policy, our electronic meeting policy. All in favor say aye. Aye. Opposed?
Discussion. Did you have discussion?
Apologize. I apologize.
Yeah, I just wanted to make an observation or a question, if I could, of staff. Since this allows for personal reasons the remote participation by up to 25% of the meetings rounded up, and we typically have 2 meetings a year, would that mean that half the meetings someone can participate remotely without an illness?
Mr. Chair, Delegate McNamara, yes, under the policy, you can use remote up to 2 or 25%, whichever is greater. So yes, they could use 1 remote participation if we had 2 meetings.
Thank you. And I'm going to vote against it just because I think there's an awful lot of value to us being here in person, and I think this allows us literally to miss half the meetings without an illness. Thank you.
Is there any further discussion?
Mr. Chairman,
Senator Surville.
just really quick, I think we had 27 bills from the last either 2 or 4 years that we didn't act on, and I suspect if we're going to get to the bill volume that's referred to us, we're probably going to need a lot more than 2 meetings, but that's just my suspicion, so.
Is there any further discussion? Okay, all in favor of adopting this is the electronic meetings policy, say aye. Aye. Opposed, nay? Okay, 1 nay. 1 no, the usual suspects, okay? We've adopted the policy. Now we have an overview of the commission from staff.
Good morning, everyone. My name is Sarah Kinzer. I am a staff attorney with the Division of Legislative Services, and I will be giving a brief overview of the Commission's powers and duties. So I'll go over the powers and duties of the Commission, discuss some statutory background on mandated benefits, describe the assessment process for proposed mandated benefits, and then the Bureau is presenting about the essential health benefits benchmark plan process. So I will skip that section and briefly discuss legislation that was referred during the 2024 session to the Commission. The Commission is tasked with monitoring federal and state implementation of the Affordable Care Act, receiving information provided by the Bureau under 30-343 of the Virginia Code, and assessing the implications of the ACA's implementation on Virginia's residents, businesses, and general fund. HERC is also tasked with considering the development of a comprehensive strategy for implementing health reform in Virginia, including recommendations for innovative healthcare solutions independent of the approach embodied in the ACA. HERC also receives reports from the Bureau pursuant to 30-343 and recommends health benefits to be included within the scope of the essential health benefits provided under health insurance products offered in Virginia, including benefits not required by the ACA. Upon the request of the chair of the House Committee on Labor and Commerce or Senate Committee of Commerce and Labor, HERC assesses proposed mandated benefits and providers and recommends whether such benefits or providers should be provided under health care plans offered through or outside a health benefit exchange. HERC also conducts other studies of mandated benefits and provider issues as requested by the General Assembly. And finally, HERC is required to develop appropriate recommendations for legislative and administrative consideration to increase access to health insurance coverage, ensure that costs to purchasers are reasonable, and encourage a robust market for health insurance products in the Commonwealth. Next are a few statutes that are useful to keep in mind when discussing mandated benefits. First, the Affordable Care Act permits states to require a qualified health plan in such state to offer benefits in addition to the essential health benefits. For any additional mandated benefit, the state shall make payments either to the enrollee or to the qualified health plan on behalf of such enrollee to defray the cost of the benefit. Virginia code provides that a plan cannot be certified as a qualified health plan if that plan offers any state-mandated benefit in addition to the essential health benefits. And then finally, in this section, any law imposed under Title 38.2 becoming effective after July 1st, 2009, providing for an insurance mandate for policies of accident and health insurance shall also apply to health coverage offered to state employees pursuant to 2.2/2818. So next is the assessment process for proposed mandated benefits. This is governed by 30-343.
Thanks. Heck, sir, I had a quick question for you. All the legal stuff you just went through before under state law, my recollection is that a lot of that is required by federal law, including, I think, the existence of this commission. Am I off on that?
Mr. Chair, Senator Serval, I don't think the ACA requires the existence of this commission. It does require certain things about mandated benefits, including state defrayal of costs for mandated benefits that exceed the essential health benefits enacted after the ACA was enabled.
Got it. But the further question, Mr.
Senator
Chairman.
Serval.
Federal law also, though, requires us to adopt a new benchmark plan. What is it, every 4 years?
Mr. Chair, Senator Serval, federal law requires adoption of a benchmark plan. It does not require that it be updated.
But we did require that last year under state law, I think, right?
Yes, sir, we did require it under a bill that you carried, sir.
Right. Okay. Thank you.
So next I will discuss the assessment process for proposed mandated benefits. This process applies to proposals for mandated health insurance benefits or providers, which are defined as health insurance coverage required by the Commonwealth that is not mandated by federal law and includes coverage for specific health care services or benefits, limits or restricts deductibles, coinsurance, copayments, or maximum benefit amounts, or includes a specific category of practitioners from whom an insured may receive care. So the first step in the process is that the chair of the House Labor and Commerce Committee or Senate Commerce and Labor Committee will request the HRC to assess a proposed health insurance mandate and send a copy of that request to the Bureau. From that time, HRC has 24 months to complete its assessment. Upon the Bureau's receipt of that request, the Bureau shall prepare a Step 1 analysis, which will address the extent to which the proposed mandate is currently available under qualified health plans offered on the exchange, and whether CMS has determined or would determine that the proposed mandate exceeds the scope of the essential health benefits according to the ACA. Next, the Bureau will present the results of the Step 1 analysis at a scheduled commission meeting. That presentation will provide background information and address whether the mandate likely exceeds the scope of the essential health benefits, whether the mandate would likely lead to increased state costs, and the extent to which the coverage proposed is already available. After the Step 1 analysis, the HRC shall determine whether the proposed mandate shall be considered as part of an essential health benefits benchmark plan review, assessed jointly by the Bureau and JLARC in a Step 2 analysis, or considered in another manner by the HRC, which may also include no further analysis or action. For the Step 2 analysis, the Bureau and JLARC will provide 2 separate but coordinated reports and will present the results at a scheduled HRC meeting. The Bureau's assessment will focus on the financial impact of the proposed mandate, while JLARC's assessment will focus on the current status and need for the proposed mandate. After the Step 2 analysis, the HRC shall determine whether the proposed mandate shall be recommended to the General Assembly, considered as part of the Essential Health Benefits Benchmark Plan Review, or considered in another manner by the HRC, including no further action.
Now, Sarah, correct me if I'm wrong, but the 4 bills we've got listed on item 6 on the agenda are 4 that have been through step 1 analysis, and they're ready for consideration by this commission. We can consider them, we can make a vote on them today, or we can do it in another meeting. We don't have to decide today. But these are the bills, the 4 bills that we have to consider today. We have to consider.
Mr. Chair, that is correct.
Okay.
Thank you. The next section discusses the essential health benefits benchmark plan process. I will go ahead and avoid repetition. The Bureau is presenting on that process after this. So the final slides are in relation to legislation that was referred during the 2024 session to the HERC. That includes HB 230, 513, 604, 610, 760, HBs 935, 946, 1347, and Senate Bills 118, 376, 1347, 333, and 735. Thank you, and let me know if there are any questions we can answer.
Are there any questions of Sarah? Okay, the next thing on the agenda is update on electronic. We're going to hear from the Bureau of Insurance. We're going to hear from the Bureau of Insurance on this item. Yes, ma'am, welcome. Can hear you.
Excellent. Good morning, Vice Chair, members of the Commission. My name is Rebecca Allen. I am the Chief Policy Advisor for the Bureau of Insurance, here to give you an update on the Essential Health Benefits Benchmark Plan Review process. As staff had already briefly touched upon, when you are looking at the Step 1 and Step 2 assessments as part of the mandate review process, one of the options that is available to you is to have the bill considered to be part of the Essential Health Benefit, or EHB, benchmark review process, in addition to the other options that were already presented to you. So with the EHB benchmark, that is the minimum standard for which all new individual and small group plans are modeled, including specifics on how the EHBs are covered. The Affordable Care Act, or ACA, requires states to set or default to a set of EHBs to be provided in every policy, again, for individual or small group health insurance coverage. There is no requirement for the state to update or revise its existing EHB benchmark. If it opts not to do that, it will continue with the EHB that it last adopted. Per CMS, the Centers for Medicare and Medicaid Services, EHB benchmark plan doesn't set cost sharing requirements. So what are the EHBs? So under the ACA, it's a set of 10 categories of benefits that non-grandfathered health insurance plans must cover. You can see the list here on the screen. It includes ambulatory patient services, lab services, maternity and newborn care. This is the universe of what EHB is. Some things are not considered to be EHB. Specifically, routine non-pediatric eye exam services are not EHB. Long-term / custodial nursing home care benefits are not, and non-medically necessary orthodontia. A health plan, this is federal law, a health plan does not fail to provide EHBs solely because it does not offer abortion services, and that comes straight from federal law. I will also note this is a relatively recent change about the eye exam services, not eye exam services, about non-pediatric care. Previously, routine non-pediatric dental services couldn't be considered EHB, but CMS just came out and has changed that. So routine non-pediatric dental exam services or just dental services generally, can be included in the EHB benchmark plan. It's not currently here in Virginia, but that is something that could be considered. I just wanted to call that out because that is a change from the last time Virginia went through the EHB benchmark plan review process. A health benefit may be included in the EHB benchmark plan even if there's not a previous state action mandating the provision of that benefit. So When these bills come before you, obviously there's been a state action. Someone has filed this bill for consideration, and one of the standing committees has referred it over here for consideration, at which point you all, at the end of that process, can kick it over for the EHB benchmark process. However, as we're going through that EHB benchmark plan review process, other benefits can be suggested for which there was no preceding legislation filed. So I just want to put that out there as HERC begins considering what they want the benchmark to be in 2025. There is nothing that says that there has to have previously been legislation that was considered via the Step 1 and Step 2 process. Plans will be certified as a QHP, a Qualified Health Plan, if it meets the EHB benchmark plan, with some exceptions for grandfathered plans. Any benefit not included in the EHB plan that's required by state action, so passed and enacted, that takes place on or after January 1, 2012, that's considered in addition to EHB. The state, of course, can mandate those benefits outside of the EHB process. They would be considered in addition to EHB, but in doing so, that's going to trigger a cost or a requirement that the state defray the cost of that extra benefit that's being added. And we have had some of those occur since the last time we had adopted the EHB benchmark. So the hearing aids for minors, that was one that triggered, it was considered in addition to EHB, that triggered the state to defray the cost of that new benefit. Some things are not considered to be in addition to EHB. Any mandates that the state enacted prior to 2012, mandated provider or cost-sharing requirements, technical corrections not related to the bill, mandates that are related to the method of delivery of care. So telemedicine is the most common example. Any mandates that were enacted to comply with federal law, we've given a number of examples here on the screen, and mandates for a benefit covered in the EHB benchmark. So if it's already in the benchmark plan, but then the state decides to pass a bill reiterating that, that's not considered to be in addition to EHB. So we have had prior EHB plans selected. Each plan, like as I said earlier, you either have to choose or default to an EHB benchmark plan. In 2014, Virginia, by letter from the then governor, chose the default benchmark, but we did make a slight change to it. We did substitute the Medicaid Smiles for the default pediatric dental EHBs. We also had to do that again in 2017. And in 2023, the General Assembly had passed a bill that required BOI to select a new HB benchmark plan for 2025. That revision included prosthetic devices and components and formula and nutritional products as medicine. So let's jump ahead to Senator Sorovel's bill that he referenced during the prior presentation. So again, last year in 2023, a process was created in state law on how to tackle EHB benchmark plan review process. What will that look like here in Virginia? So it's a periodic review process. It will occur every 5 years, beginning here in 2024. A stakeholder work group is the first step in that process, and as mentioned, it may result in adoption of a new benchmark plan if that's ultimately what Virginia decides to do. And that would be effective for plan year 2028 and forward. The Bureau of Insurance is the one who facilitates that work group. We report back on the work group's activities to HERC. The analysis that we provide as part of that is advisory only. HERC is welcome to accept or reject in whole or in part any of the analysis that we provide following those stakeholder work group meetings. HERC considers those findings and recommendations when identifying what benefit changes to include in the application to change the EHB benchmark plan. So we've engaged a contract actuary to provide technical assistance for the work groups and to help prepare a potential application to adopt a new EHB benchmark plan. We've met 3 times with them already this summer, and our last and final meeting we are planning to have on August 22nd from 1 to 4. So this is the overall timeline. As previously mentioned, now 2024, we are convening stakeholder work group meetings. On or before March 31st, 2025, we will be reporting to HERC on work group findings and assessments of proposed benefit changes. Before June 30th, 2025, HERC conducts 2 public hearings regarding potential benefit changes. And the deadline for HERC to determine if there is going to be a new benchmark plan and what those potential changes should be further analyzed, that deadline is also going to be June 30th. Once that decision has been made, BOI would present an actuarial analysis of those benefits that have been identified by HERC. And again, this one's conditional. If the decision is to move forward with a new EHB benchmark plan, then HERC will need to conduct 2 more additional public hearings before the end of 2025. And then HERC will need to determine, after hearing all of that information, receiving the actuarial analysis from BOI, what ultimately is going to be the potential benefit change, if any, to be included in the benchmark plan. And then, of course, the federal deadline to apply is going to be May 2nd, 2026. And again, that would be for plan year 2028 and forward. As you can tell, if HERC makes a determination by the end of the year in 2025 and the deadline is May 2nd, 2026, that means that there is going to have to be legislation in the 2026 legislative session that directs BOI then to apply for that, to select that new benchmark plan that includes those specific benefit changes and make that application to the feds.
And I want to make clear that what you just said, Senator Servell said this commission doesn't meet enough, but we're required to have 2 public hearings next spring.
Sometime before June 30th, 2025. So you can space them out. You can have them back to back, whatever you would prefer. And again, if the decision is to apply for a new EHB benchmark plan, that would trigger the requirement for 2 more meetings beyond the 2 that you've already had prior to June 30th.
Mr. Chairman.
Senator Servell.
I also want to make clear that the legislation was also carried by Delegate Byron. It was a bipartisan idea.
All right. Thank you.
Thank you, ma'am. Are there any questions from the commission? Does anybody have anything they want? Delegate Helmer.
Thank you. Mr. Vice Chair, I just ask, are there any guardrails in terms of how we have to think about if we're going to add essential benefits to the essential health benefits plan in terms, I mean, is it open season, or is there a specific way we should think about it in terms of, what you can add? Is there analysis that's already been done on what other states have on their EHB plans versus us? It would just be helpful to know what the guardrails that exist and freedom of maneuver.
Sure. So with the disclaimer that the Vice Chair and Delegate Helmer, yes, so there are some guardrails in the form of there has been legislation that HERC has sent over to the for the EHB review process, so those would definitely be within the realm of what we would be considering. With our contract actuary, they are also looking at what other states have done, what those costs have been. But as I previously mentioned, it's entirely possible that either the stakeholder work group or HERC itself comes up with benefits that were not previously considered as part of legislation. There are guardrails in that the EHB benchmark plan cannot be more generous than the most generous employer offered health insurance, and it can't be less generous than the least generous health. So there's a band in which it has to fall, and that's why we have the contract actuaries on board, is to help us identify, are we falling within that band? We're not being too generous and we're not being too stingy, essentially, with the benefits. So it's got to fit within that band. So, and that's why we have the contract actuaries on to help us out, because if you pick, let's say, these 3 benefits, that might keep you in band, but if you want this 4th benefit, you might have to drop 1 or 2 of those. So they're the ones to help us calculate what your options are going to be. But there is a band in which you have to fall from an actuarial standpoint.
Delegate Helmer.
Thank you.
Are there other questions? Thank you very much.
Thank you.
Well, the next thing on our agenda is for us to take up the Step 2 analyses that we've previously requested. We have 2 bills from the Bureau of Insurance and 2 bills from the Bureau of Insurance and JLARC. So HB 240, I guess, from the 2022 session.
Thank you, Mr. Vice Chair, members of the Commission. My name is Brad Marsh. I'm the Health Insurance Policy Advisor with the Bureau of Insurance, and I'll present on HB 240 here, as well as another bill, and then we'll move on to the joint analyses that both JLARC and we have worked on. So for each of these bills, the BOI will present, and this goes for all 4 of the bills that are on there. We'll present a summary of the bill, an overview of the current coverage in Virginia, the expected impact on the utilization of services and providers, the expected impact on premium cost and the administrative cost to insurers, the expected impact on total cost of health care in the Commonwealth generally. We'll also look at the expected additional cost to the state of defraying this benefit under the ACA if it is determined to, if they are bills that are determined to be outside the scope of the EHB. So moving on to HB 240, which addresses insulin cost sharing. This proposed mandate requires that carriers cover at least one prescription insulin drug in each therapy category at an amount that does not exceed $30 per 30-day supply. Carriers will be exempt from this requirement if their cost share for all insulin drugs is not greater than what's required under an insulin discount program that's also established under the same bill. And, or if they cover at least one prescription insulin drug for the treatment of diabetes in each therapy category under the lowest tier of drugs. As the insulin discount program that was proposed under the bill hasn't been established because the bill was tabled, we don't know what the prices would be of the cost share on those bills, so we're not able to establish whether carriers would currently meet those requirements. So instead, we evaluated whether they cover at least one prescription insulin drug for the treatment of diabetes and at the lowest tier of drugs, and whether they meet that $30 per 30-day supply, and that was what this analysis was based on. This slide right here just takes a look at what responses we got from the carriers in the marketplace. We queried them on their current cost sharing for these drugs. We received responses from 10 carriers. Their representation of the individual the market segments there is a little bit different between each of these, but all of them had a pretty substantial, more than half of the market was represented in the carriers that responded. And that's based on total member months. Member months are just taking each monthly enrollment of the plan for an entire year and adding them together so that an individual who is enrolled for the entire year would be enrolled for 12 member months. So current coverage in Virginia, under existing law, carriers must set their cost-sharing payment at an amount that does not exceed $50 per 30-day supply, and that's regardless of the amount or type of insulin needed to fill the covered person's prescription. So folks should not be paying more than $50 per 30-day supply at this point. On the impact on utilization, for the purposes of this analysis, the utilization of insulin drugs is not expected to increase as a result of changing these cost shares. And now we'll get to the expected impact on the actual premium costs. So this proposed mandate could result in an increased cost to carriers because they won't be able to collect as much in their cost share as they would. They would lose that $20 extra in cost share that they're allowed, moving from that $50 to $30. And that would then be passed on to, that could potentially be passed on to other folks that have that insurance as a increase in the premium cost there. So based on carrier reporting, the impact on premiums is expected to be around 23 cents per member per month. And there's a little bit of variation between market segments there, mostly on the basis of the different administrative costs that are allowed within the large group market versus the small group and individual markets under the ACA. So this mandate wouldn't be expected to impact overall healthcare costs, but it would result in a shift of those costs as individuals who purchase insulin drugs would see a lower monthly amount that they need to pay for those insulin drugs, and carriers would then pay a larger share of the cost of those insulin drugs directly and could raise premiums to compensate for those expenditures. Based on the current cost share per member per month analyses, the total costs shifted by market segment are estimated to be about $1 million in the individual market, about $812,000 for the small group market, and about $2.7 million for the large group market. On ACA defrayal costs, because HB 240 only addresses cost sharing for an existing benefit, it would not be considered a mandate under federal law and would not be subject to defrayal. One thing I would note here is that state law that brings things in front of HERC is a little bit different definition of mandates than what the federal government does, and that's what ends up with these mandates that are only cost sharing ending up here at HERC.
What are the differences?
The difference there is that they don't consider cost sharing or the change of providers or identification of new provider types as being things that are mandates subject to defrayal under federal law here.
You know, that $50 cap was placed, that was a statutory change, wasn't it?
That's correct, Mr. Chair.
What year was that?
That is a good question. Is it 2020?
21? Okay. Okay. I'm sorry. You go ahead.
No worries. Thank you, Mr. Chair. And so as we get to sort of the end of this presentation, we did want to present a list of what the options would be for HERC related to this bill, and just sort of lay out these things because they are a little bit different for the different bills that we have here, the nature of their posture. The HERC could recommend HB 240 in its current form. It would not be subject to defrayal, and because it would not be subject to defrayal, it would apply to all the markets, including the qualified health plans out there. You could recommend HB 240 with any changes that HERC would like to see in that bill from what the statutory language was in the original proposed bill. Because the Essential Health Benefits Benchmark Plan doesn't set cost-sharing policies, this mandate can't be recommended for inclusion in the HB Benchmark Plan review because there's not really a way to impose that.
Okay, I guess we are at a decision point now. Whether are we going to decide these bills as we go, or are we going to defer decision, or you want to wait till after we hear about all the bills first?
I recommend one at a time.
One at a time. Okay, HB 240. You've heard other questions. Senator Servell and Delegate Helmer.
So I just want to make sure I'm clear on what you're saying to us there. I think you said when you total up all the cost shifting you had there, I think it came around $3 million a year. So I think what you were saying is that, trying to simplify this a little bit, is that what this bill basically does is says that people who don't have diabetes are going to be paying an extra $3 million for people who do have diabetes, so that they don't have to pay like an extra, what, $20 a month, right?
Mr. Chair, Senator Servo, that's exactly right. The likelihood would be that those costs would be spread across all folks that are enrolled in plans, and they would each see that 22 to 23 cents per member per month increase. So each person, regardless of whether they have diabetes, would see somewhere around, I guess that would be about $2.50 or a little more than that per year in their total premiums paid.
It's like a $4.5 million increase for
$4.5 million. Mr. Chair, I had one other question.
Senator Servell.
And I think what you also said, based on your review, and I can't remember if this is for you or J-Lark, that the adoption of this change would not provide any new coverage to anyone. It just would affect what's already existing coverage. So we're not covering any new people through this extra money we're putting into the program. We're not picking up any new benefits for anyone, right?
Mr. Chair, Senator Servell, that's exactly right. We wouldn't be adding, the analysis does not project any new individuals coming in there. It's just a change in what they would be paying per month and spreading that out amongst everyone who pays for their insurance.
Delegate Helmer.
Sorry, Mr. Chair, I'm learning how the Senate buttons work. Mr. Chair, just a procedural question, and then I have a question about this study. Each of these is going to have a premium impact, presumably, right, as we go through it. So I just wondered if it might make sense, since we have to evaluate the total cost of what we're doing, to actually take them up all at the end, one by one, all at the end, so we could, because it's relative.
We can certainly do that, Delegate Helmer. That's fine, but it makes sense to go ahead and ask questions about the individual bills and flesh them out one by one.
Yes, and then quick just question for you, sir, which is
Delegate Helmer.
When we're looking at the cost and the cost transferal, is essentially the actual assumption that there's no competition in the insurance market. In other words, that different players in the health insurance market won't absorb any of the costs, that they'll pass them all on to consumers. Is that the essential underlying assumption as it goes?
Mr. Chair, Delegate Helmer, that is correct, and that's why we use the term could there, because we don't really know what the actual impact would be. What we would like to show is what the sort of maximum impact would be if all of those costs were passed through, sort of the actuarial setup being the same there, that we would end up with that being the sort of top end of what would happen if the carriers took all those costs and passed them on.
Thank you, Mr. Chair.
Delegate Nadeau, your light's on.
Yes. Thank you, Mr. Chair. Just to clarify, so these numbers assume sort of the numbers are what they are. If everybody moved forward, had this benefit, and it was spread across the pool. Do we have a sense of what the fluctuating numbers are, people participating in these programs sort of over time so we could have a sense of what potentially could look like beyond the numbers we see here. So for example, year over year or every 3 years we see this kind of shift in the population set.
Del Maldonado, Chairman Deeds, I believe we could look into those and do some analysis. We did not do any sort of longitudinal analysis here, or looking at maybe a sensitivity based on how folks move in and out of small group and individual group markets. The analysis we did, it would not change those per member per month numbers, but in terms of the overall dollar numbers out there, because those are gotten to by applying the actual enrollment to those per member per month, those total dollar amounts would likely change. But we would not likely see, without some change in utilization across these market shares, any difference in the analysis from a per member per month cost standpoint on premiums.
Thank you.
Okay, Senator Surville.
I had another question. So, based on looking at all the other plans in the market, can you tell us like how many are some plans already at 30 a month, or are a majority already at 30, or how many are at 50? Do you have any sense of that?
Mr. Chair, Senator Surville, we did have several plans that did report that they were charging either a $0 copay, at least for at least one of the insulin drugs in each category there. We did not do an analysis. We could look at that and give an analysis of what percentage would currently meet that market. What we did was take the total cost share that's currently being collected and basically divide that by all of the member months of the carriers reporting to get that number, so that some of the carriers were reporting $0 there and some of them were reporting that. Those who were charging all indicated that they were charging that $50, up to the $50 fee there. So you would either see generally $50, or some of the carriers did indicate that they were charging $0, at least for one insulin drug in each of these therapy categories.
Senator DeSteph.
Mr. Chair, my question is very simple. What percentage of the insurance market have diabetes? Because it looks like about 1% of the cost will be distributed amongst everybody for this. So what percentage of the individuals in the plans have diabetes that need this medicine?
Mr. Chair, Senator Steph, we did not query the carriers on that in particular. We could infer some things based on the total claims and the total members that were there. I think we could probably go back and get you that number based on the analysis we already have, or we could certainly reach back out to the carriers and get an answer on that.
And then, Mr. Chair, one last
Senator
follow-up
DeSteph.
is, from the income perspective, it would be better if we understood what was the income of the population that has diabetes. So are a majority of the individuals in the lower income bracket, middle income bracket, or high income bracket?
Mr. Chair, Senator Steph, we don't know that, but we can certainly look into what information is available out there that would give us some idea of the breakdown of these folks and who this would fall on. I'm not aware of any differentiation there, but there may very well be something that there are groups that have higher prevalence of diabetes. We're not aware of anything that would make that between the different market segments there, but in terms of what people's income is, there may very well be a correlation there.
You're interested in a breakdown of where the diabetic population is?
Mr. Chair, that's correct. I'm trying to find out, is it affecting a specific demographic?
Yeah.
And then, if we're talking about roughly $2.50 going up for everybody, and the average person, we're talking about $20 a month, the increase are roughly $240 a year, so that tells me maybe 1% have diabetes. And I'm just trying to infer this with the limited data we're looking at. And then I'd like to see what truly that impact is, and do these folks need that savings of $20 a month?
Is it possible to get that sort of demographic breakdown?
Mr. Chair, I think we could certainly look at what's available out there. I'm sure there have been some studies on diabetes and its population prevalence, and can certainly get to that, or like I said, query the carriers and ask them to tell us how many folks they have with a diabetes diagnosis.
I'd be shocked if, for example, if it was as low as 1%.
And Mr. Chair, I feel kind of the same way, but I don't know enough about diabetes or those affected by it. So I'm asking questions out of ignorance. I just truly don't know.
Mr. Chair, I think those are incredibly reasonable questions, and we can go back and get that and try and get that information for you all and get you at least something else to go on here to answer those type of questions that you have.
Are there additional questions of the Bureau of Insurance? Delegate Maldonado.
Thank you, Mr. Chair. I just want to add on to Senator DeSeff's request is that I think it would be also helpful to see the age ranges of those folks as well, because if they are children or they're elders, or I think that has some bearing as well. Thank you.
Are there other questions? I think it makes sense to defer the decision on this bill until we get some more information about it. Is that a consensus view? Okay. So we'll go to the next bill, House Bill 477 from 2022.
Thank you, Mr. Chair. HB 477 will be the next assessment that we'll present to you all here. HB 477 addresses prostate cancer screening and cost sharing for those cancer screenings. This proposed mandate would prohibit cost sharing on the prostate cancer screening benefit that is currently mandated of one prostate-specific antigen test in a 12-month period to persons age 50 or older or persons age 40 or over who had a high risk for prostate cancer. This would result in members paying nothing out of pocket at the time of service, those who do access these services, but premiums for all members, even those who do not utilize this service, may increase, similar to those lost revenue from dropping $20 from 50 to 30 in the diabetes bill, or in the insulin cost sharing bill. BOI queried carriers on their current utilization of these prostate cancer screenings and the cost share that they impose on those claims. We received responses from 10 carriers that represented these proportions of each market by total member months. These were a different 10 carriers than you saw on the last slide, and that's what differentiates between the percentages of the market here. These were carriers that represented slightly larger percentages of the individual and I believe small group market. But in each of these market group segments there, we're looking at more than 70% of the carriers, or carriers, I'm sorry, representing 70% of the total member months. The current coverage of prostate-specific antigen tests, currently state-regulated carriers are required to provide one in every 12-month period to those two categories that we discussed earlier, folks over 50 and folks 40 and above that are high risk. Some, but not all, carriers indicated that they provide prostate cancer screening benefits as a preventative service without cost sharing. It is not required as a preventative service at the federal level. And carriers reported that overall, 84% of their prostate cancer screenings were provided without any cost share. Within the members who did incur a cost share, the average cost share per claim, so what a person actually paid out of pocket on average, to receive a screening was $33.63. Those range from a low of about $12.55 to a high of $84.10 for, and those are averages within a given carrier rather than the $33.63, which is across all carriers.
Mr. Chairman.
While carriers submitted data that we had in terms of...
Senator Serval.
Oh, sorry.
I'm just trying to make sure I'm clear on what you're presenting here. So you're saying that in the three markets, 70 to 73% of the providers responded to you.
That's correct.
Okay, and then within that set of providers that responded to you, they told you that 84% of screening benefits were provided without cost, so that this bill would only affect about 16% of screenings?
Mr. Chair, Senator Serval, that's correct.
Okay, Mr. Chairman, one last question.
Senator Serval.
Just so when you say 84%, how do you arrive at that? Because I mean, some carriers represent a lot more customers than others or whatever. So is it 84% of the overall population, or is 84% an average between the ones who responded, or what?
Mr. Chair, Senator Serval, 84% was the total number of prostate screenings that were reported for 2003 by the carriers that responded to the study, and 84% of those individual screenings did not have a cost share associated with them. So we're done at zero cost share. 16% of the prostate screenings that were done did have some sort of cost share involved in it. And then within those, that 16%, that's where the results that are on the third bullet point here about what they paid. So taking the total dollars and dividing by the number of folks that got a screening.
Okay, Mr. Chairman, one last question.
Senator Servo.
And I also just saw Delegate McNamara hit his speak light, and I'm pretty sure that the way the system works, the speak thing notification doesn't actually operate in commission meetings in the Senate for some reason. So you probably just need to pipe in if you want to ask a question.
Thank you.
But so is it fair to say that basically what this bill and to some extent the last bill are seeking to do is to try to bring in some ways it would bring a sort of small minority of providers into line with what the vast majority of the market is already doing, at least amongst the 70% who responded?
Mr. Chair and Senator Servo, I think partially that, although I would say that the prevalence of folks receiving a screening and paying a cost share was not just in single carriers there. Almost all of the carriers had some group of folks that were receiving a benefit with some cost share to it. So it was more that the 84% of the folks enrolled in each of these programs have coverage that is giving them that screening without a cost share, rather than it being that there's the vast majority of carriers are providing it to all of their members without a cost share. Each one had some proportion, not each one, but a large portion of them had some folks that were paying some sort of cost share on it for whatever product they had purchased.
Got it.
Delegate McNamara.
Thank you, Mr. Chair. So potentially some of that 16% would be people that this bill would not cover. They might be getting a second PSA screening in a given year. They might be 22 years old that want a PSA screening for some odd reason. Would that not be included in that 16%, which would not necessarily be covered by this bill?
Mr. Chair, Delegate McNamara, from the way that we queried the plans, they were only supposed to be reporting on prostate screenings that had been provided to folks either between 40 and 50 or 50 and above.
Okay, thank you.
And if they responded correctly, which we believe they did, based on the utilization they gave to us, we would assume that is all folks that this would apply to.
Okay, are there other questions? And I apologize. Generally, there's a queue of people who have requested to speak, but that function's not available today. So please go on, Mr. Marsh. Thank you.
I believe we were here on expected utilization. So the data that we received did not indicate a greater utilization of prostate cancer screenings in carriers with lower per member cost share. Granted, the carriers with lower cost share only accounted for 16% of the data submitted, so we really couldn't draw any across-the-board conclusions, but just to note that we didn't see a correlation between those two things. We would need to do a different study to actually determine if there's possibly an impact of lowering this cost, but all that would do would be applied to that 16%. So this slide here then goes into the expected impact on premium cost. We did divide out the two parts of the bill, or the two groups that it would apply to, and come up with a specific per member per month cost there for the 50 years and above, and the 40 to 49 years, and then sum those two there at the bottom. But just like in the insulin cost sharing, prohibiting cost sharing on prostate screenings could result in an increased cost to carriers, as they would be directly responsible for basically the entire cost of the prostate cancer screening, since we're taking away that cost share. Now, based on carrier reporting, the impact on premiums is expected to be around 4.6 cents per member per month, with some variation between market segments, once again, as a result of the administrative cost differences between the large group and small group and individual markets. As noted, this mandate would not impact overall healthcare costs, but would result in shifting those costs from the individuals who utilize prostate cancer screenings to the carriers paying those costs directly, and then potentially raising their rates to compensate for those expenditures.
And just so we can compare apples to apples, I guess under the last bill, you would have had about $4.5 million of cost shift from one group to another. This bill would shift to less than $900,000.
That's correct, Mr. Chair. And as noted before, because HB 477 addresses cost sharing for an existing benefit and does not expand that benefit, it would not be considered to be a mandate under federal law and would not be subject to any defrayal.
Mr. Chair.
Senator DeSteph.
Mr. Chair, I'd have the same questions under this bill that I had under the previous one. Pretty much the exact same. Again, just not being a subject matter expert in this area, just to have the information and give me an opportunity to research it a little bit more.
More information is always a good thing, but the other bill was a little bit different because it applied only those people that had diabetes. This is a bill that anybody over 40, any man over 40, any man over 50 is going to benefit from potentially. Is that correct?
Mr. Chair, that's correct. So, I mean, the idea being anyone over 50, at least in terms of what this bill addresses, would be equally likely to utilize these services.
Senator DeSteph, I guess, what kind of information do you think we need?
Well, I guess to be honest with you, I don't know enough about it, so I've got to research it a little further because I don't even know what screening process they do. So is this just the annual glove expiration, or is this all kinds of other things? Blood test?
Yeah.
Okay.
Senator, our Delegate Maldonado, I'm sorry.
Thank you, Mr. Chair. So I do think this one is a little different. We have seen from the data that this prostate cancer is particularly high in African American communities, and particularly with respect to African American men. And I think there was some global studies recently that also looked at some of the more affluent countries where there was a 67% increase. Although our death rates are lower in the more affluent countries, there still is an increase. I believe that even Petersburg might even have a very high incidence of prostate cancer. So this is alive and well in our communities. And I do think it is different from the other bill, and think that the no cost sharing to be able to protect our men in this area, or anyone in this area, is very vital. Thank you, Mr. Chair.
Delegate Maldonado, this is a different bill. If Senator DeSteph wants additional information, I don't think we should. That makes sense. That's all right with me. But I think this is a different bill. We can certainly vote on it.
It's up to the will of the committee, Mr. Chair. I don't mind one way or another. I'm going to do a little more research into it because, again, I'm not a doctor. I'm not very familiar with a lot of the medical procedures and a lot of these things here.
Well, this commission only makes recommendations anyway. It has to go back before the General Assembly.
Understood, Mr. Chair.
It's up to you.
Yeah, it makes it. Are you complete? Is your presentation on 477 complete?
Mr. Chair, the last slide that I have here is just the HERC options. They are very similar to what we saw on the insulin cost sharing, just making the point that it can't be done through the HB benchmark plan, and that it would not be subject to defrayal, and because it would not be subject to defrayal, it would apply to all markets.
Okay, well, I think this bill is enough different that we could certainly take it up if we chose to. Are there those in the public who would, particularly providers, who would like to speak, or anybody else would like to speak about this bill?
Mr. Chair.
I just had a question for the BOI. Going back to your slide that said there was no impact on, essentially lowering premiums seems to have had no impact on how many folks availed themselves of the screening. Is that, in your experience on other things, is that common that there's no actual, like I would expect if it's cheaper, more people did it, and do you have any?
Mr. Chair, Delegate Helmer, that was counterintuitive to me as well as we looked through this. I would think that there probably is some evidence out there, although we just did not see it within the data that we had, so we decided to not assume any level of utilization change in there. We could certainly do some sensitivity analysis on this, if that was something that you wanted to look at and say, if we doubled or tripled the number of screenings that were going on, say in that 16% of folks, what would be the impact? It would not be to triple that dollar amount because it's only going to affect that smaller 16% of folks there. But if we wanted to look at that in any way, or if that would affect decisions on that, the Bureau would be happy to go and look into that analysis and potentially do some literature review as well.
We can certainly wait and get more information if you'd like, or we can take the bill up today.
Mr. Chair, I just, being new to this, one of the reasons we would look at doing something to increase, essentially. I'm really struggling with the technology. One of the things I would think we would look at increasing premium costs is that it's a positive impact if more people are taking advantage of the screening. I wonder, and I'm very open to what everybody else in the commission thinks, is just if it's worth coming back and taking a look at whether there is a suggestion as we make this decision to impact premiums for a broad swath of people that we would find out if there's efficacy on the other side of it.
My understanding is that this used to be a recommended procedure, and now the recommendation is that you talk with your doctor about it. It's not recommended necessarily a recommended procedure anymore. Is that correct?
Mr. Chair, I believe that's true. The U.S. Preventative Services Task Force that lays out the policies that define what is preventative versus what is not have looked at some of the evidence on there, and I think found there to be potentially more, maybe a balance between those potential costs and risks that go along with it, and has moved it down from, I guess, an A category to a B or a B to C, whatever that is that they do. But it is not currently required under federal law to be a preventative service.
Mr. Chair.
Senator DeSteph.
Are we going to open it up for public hearing? I know we have Heidi Dix here. I know we have Jeremy Greenfield.
We did. I've already asked for people from the public to speak, and
all right.
So
I was hoping maybe they could chime in with something, but I guess we already asked for it.
I think based on some of the questions, we might be able to get some more information about this, and deferred decision on this. We aren't in any rush anyway. We're going to meet at least twice more before the end of the year. So let's move to the next bill.
All right, Mr. Chair. So that is the end of the bills that BOI will be the only one presenting on. Moving on to these next bills, JLARC is going to present their part of the analysis first, and then we'll follow up with this sort of information.
Okay,
on those
thank
bills.
you, Mr. Marsh.
Mr. Chairman, I had a question for council.
Senator DeSteph, or Senator Servell. I apologize. You look so much alike.
Close, but
Yeah.
Yeah, we coordinated today. Tom or Sarah, I'm trying to remember from what happened. I guess it was back in November or December when we met and recommended these bills for step 2 assessments. But my recollection is that we considered a whole series of bills for step 2, and we had a breakdown on, we liked these bills because they were exempt from the taxpayer deferral, and we didn't like the others because they would have had a budget impact. Am I imagining things, or is that my recollection correct?
Mr. Chair, Senator Servell, you are correct that you all made decisions about a series of bills. I do not recall the reasoning of why HERC requested step 2 on these particular bills.
Okay, but further question, Mr. Chair.
Senator Servell.
But it's fair to say, though, that the 2 bills that we did recommend for step 2 they don't require any kind of taxpayer deferral of cost, whereas I think the ones we rejected, I'm pretty sure all did. Is that generally consistent with your recollection?
Mr. Chair, Senator Servell, yes, sir, that is generally consistent.
Yeah. Okay, thanks.
Okay, we're going to hear from Jay and Senate Bill 1157 from the 2023 session. I assume they're the same bill.
Yes, sir. Good morning, Mr. Vice Chair, members of the Commission. My name is Dylan Wild, and I'm a Senior Legislative Analyst with JLARC. This morning, I'll be sharing with you the findings from our review of the proposed audio-only telehealth mandate. So to give you a bit of background on the process, just a little further clarification, JLARC is responsible for Stage 2 of the health mandate reviews, in which we look at 3 questions. The first is whether there is evidence that the proposed treatment is effective. Second, we look at how commonly used and available the treatment is. And third, we assess the out-of-pocket cost to a person when the treatment is not covered by insurance. JLARC does not look at the impact on premiums of the proposed mandate or whether the mandate would result in costs that the state would have to defray. Those questions are addressed by BOI as part of their portion of the review. This slide summarizes our key findings. The proposed legislation would amend the existing mandate for coverage of telemedicine to require additional coverage of audio-only telehealth services defined as counseling interventions that address mental, emotional, and behavioral disorders. This would only apply when means of video communication are not accessible to the patient. We found that audio-only telehealth can increase access to care, and that available literature suggests that audio-only services can reduce symptoms of common behavioral health conditions. But this literature is limited, and medical experts have varying opinions on the value and effectiveness of audio-only services compared to in-person or video services. We also found that audio-only telehealth services account for a very small percentage of all behavioral health services delivered in Virginia. Mr. Vice Chair, I have 4 parts to this presentation, and I'll begin with a bit of background. National surveys indicate that mental illness and substance use disorders are relatively common, with about 1 in 5 adults in Virginia and nationally experiencing mental illness or substance use disorder in the past year. Despite the prevalence of these behavioral health conditions, many Virginians face challenges accessing care due to a shortage of providers. Estimates suggest that just over 3 million Virginians live in a mental health professional shortage area. Telehealth in general can improve access to behavioral health services in areas with a shortage of providers and for individuals who have difficulty physically accessing services due to transportation or mobility challenges. Audio-only telehealth can be particularly helpful for households that lack reliable broadband or internet-connected devices with video capabilities. Before the COVID-19 pandemic, many state Medicaid programs did not cover the use of audio-only telehealth services for behavioral health. However, during the pandemic, federal and state authorities, as well as private insurers, waived restrictions on the use of audio-only telehealth to allow for continued access to care during the public health emergency. The bills we reviewed, HB 1918 and SB 1157, would require private insurance plans and the state employee health plan to cover audio-only counseling interventions that are designed to facilitate a patient's achievement of human development goals and to remediate mental, emotional, or behavioral disorders and associated distresses that interfere with mental health and development. Under these bills, these services would have to be delivered by mental health professionals who are licensed in Virginia. In our research, we found at least 4 other states that require some insurance coverage of audio-only telehealth services. There's some variation in the standards for coverage, but these states typically require coverage of audio-only services if it is considered medically necessary and clinically appropriate. Next, I'll spend some time discussing our findings on the medical efficacy and use of audio-only telehealth. In our research, we found that there are few high-quality studies that have evaluated the effectiveness of audio-only telehealth services. However, the available research we reviewed suggested that audio-only services can be effective for reducing symptoms related to common behavioral health disorders, including depression, anxiety, and substance use disorder. These studies also found that audio-only services can be very effective for supporting medication adherence for individuals with severe mental illness. In addition to symptom reduction, several available studies found that patients who received audio-only behavioral health services were less likely to discontinue care than those who received services in person. These studies suggested that these lower attrition rates are likely due to fewer barriers to care and greater convenience associated with audio-only services. For example, transportation challenges are less likely to impact a patient's ability to attend an audio-only appointment than they would an in-person appointment. Several available studies also suggest that patients tend to be highly satisfied with the audio-only services they do receive, with satisfaction rates very similar to other service modes, including in-person and video services. Although the available literature suggests that audio-only services may be similarly effective as video or in-person treatment for symptom reduction, we ultimately concluded that additional research is necessary to conclusively determine the effectiveness of audio-only services. Currently, there are very few high-quality studies that directly compare the effectiveness of audio-only services to other treatment methods, and the available evidence is mixed on the long-term sustained effects of audio-only services for symptom reductions. In addition to the literature, we also spent some time speaking with medical experts throughout the state. And in doing so, we found that their opinions varied on the value and effectiveness of audio-only services. Some experts we spoke to felt that audio-only services were an effective treatment option for some patients and that they can be a valuable tool for increasing access to care for patients with access challenges. Other medical experts we spoke with felt that audio-only services were not as effective as face-to-face or video treatment and therefore do not offer audio-only services to their patients. Our review of the available literature suggests that this diversity of opinions among the medical experts exists nationally as well. The experts we interviewed did agree on several key points, including that audio-only services should not be the primary treatment method for behavioral health, that they should be used only if other treatment methods are not available, and that the patient should make the ultimate decision on how they receive their services. These experts also agreed that visual cues are often an important component of behavioral health treatment, and the inability to observe these cues through audio-only encounters is a significant limitation. We were unable to identify a comprehensive source of data on the availability of audio-only services in the state. However, the best available information suggests that many providers do offer these services. For example, a 2023 survey of approximately 10,600 licensed healthcare providers in Virginia, about half of whom were behavioral health providers, found that 69% offered telehealth services, and the vast majority of those who offered telehealth offered audio-only services. Although audio-only telehealth services may be commonly available, they likely make up a very small proportion of all behavioral health services delivered in the state. Audio-only services accounted for less than 0.1% of all Medicaid behavioral health claims between January 2022 and December 2023. On the provider side, one large Virginia health system reported that audio-only services accounted for only about 2% of all behavioral health services they provided over an 11-month span. And similarly, one small provider group estimated that audio-only services made up between 2 and 5% of all of the services they delivered in 2023. Mr. Vice Chair, I know I've given you all a lot of information here. I can pause here if there are any questions.
One question.
Senator Sorrell's got a question.
Senator.
So, as part of, what I do when I'm not doing this, I practice law, do child custody work or whatever, and it seems like just about every case I have involves some kind of therapy. And most of the providers that, at least my clients, which of course can afford to pay me, are dealing with their kids is telehealth. I mean, it's Zoom therapy, whatever. The analysis you just put up there, does that include therapy services that are not covered by insurance, or is that only therapy that is reimbursed by the insurance company?
Sure. Thank you for the question, Senator and Mr. Vice Chair. When we looked at the literature here about the effectiveness of these services, it didn't differentiate based on coverage. It looked primarily at some of the common counseling and therapeutic services that might be provided for some of the more common behavioral health conditions such as depression or anxiety and substance use disorder. So the literature itself does not distinguish between what might be covered by insurance and what might not be, if that makes sense.
Okay. One other question, Mr. Chairman.
Senator Sorrell.
Is there any kind of a differentiation within either in the industry or within carriers either charging differential amounts based on whether it's in person or telehealth, or reimbursing different amounts, but whether it's in person or by telehealth? Because I would assume, for example, if you're a therapy provider and you're Zoom only, you might not need all the overhead of having office space and maybe staff or no staff, I don't know, but you have less overhead to cover. So do you have any sense of that?
So you anticipated my next slide exactly, looking at cost to individuals. We did not look necessarily at cost to providers for delivering these services, but looked at the out-of-pocket costs that individuals might have to pay for these services if they are not covered. BOI might have some more information on reimbursement. We primarily looked at what providers charge here, and we found that varies significantly based on the type of service being delivered, duration, and the provider delivering that. But what they told us is that they typically charge the same amount regardless of how that service is delivered. What is reimbursed by insurers might be different, and BOI might be able to speak to that a bit better.
Mr. Chair, Senator Serval, just under the current telemedicine services statute 38.2, 34.18.16, Subsection D, a carrier should not be required to reimburse the treating provider for technical fees or cost, and however, such carrier shall reimburse the treating provider on the same basis that the carrier would be responsible for coverage for the provision of the same service through face-to-face consultation.
Senator Surville.
Okay, so Tom, basically what you're saying is that you're not allowed to discriminate your reimbursement based on whether it's in person or audio?
Well, not audio only, because that's not currently required, but under current law for telemedicine services, the carrier is responsible for coverage to the same extent they are for face-to-face. Yes, sir.
Okay, Mr. Chairman, I have one other question.
Senator Surville.
J. Lark. So it strikes me that audio only could be provided at probably a reduced cost by providers if they're audio only because they don't have to carry all the overhead, or maybe perhaps they want to live in an area that has a lower standard of living or lower living costs or whatever, so they don't have to pay as much for their mortgage or whatever, and they don't have to charge as much. Your telehealth provider could be, one part of Virginia, but providing services to people where in the most expensive part of Virginia. Did you do any research to assess whether how much is charged? For example, if you charge less, whether that makes the use of teletherapy more used more, I guess, and whether we get better results that way or anything like that. So per dollar, whatever, do you have any sense of that?
Mr. Vice Chair, Senator Sarvel, that's not a question we looked at specifically. I will say when we spoke with providers, there were no providers that delivered solely audio-only behavioral health services. They were all delivering a mix of telemedicine and in-person services and using audio-only on a case-by-case basis when it might be necessary. So to that extent, we can't necessarily speak to how the overhead might differ on an appointment-by-appointment basis, and it's not a question we looked at specifically, but I think it makes logical sense that if they were solely providing audio-only services, they would have lower costs than providing in-person video treatments. We did not see any research that spoke to the difference in effectiveness of that at all, but that's also not something we've looked particularly at. It might be something we can take a look at and follow up with you.
Mr. Chair, I was going to say, I remember when this bill came in front of us and we passed it unanimously out of the House, but I remember at the time there was pretty significant discussion on exactly what Senator Serval was talking about, and I remember that I believe there was some conversation that as we go through the process, there'll be a way that we can differentiate. What we're trying to avoid is we want to provide the service, but we don't want to create a scenario where no one wants to do face-to-face anymore because they can get the same amount of money off audio and have way lower overhead costs. And since there's a supply shortage in this marketplace, that was a big concern. And I think that's what Senator Serval's alluding to as well. And so I don't know the proper method, and we probably need to listen to the Bureau of Insurance, but I think we need to be very cautious walking forward on this without making some changes to code.
I understand, Delegate, and we need to be cautious with all these things, but there's no question that telemedicine works just to a large extent with people with mental illness, and everybody's got telephone service, not everybody has internet.
Mr. Vice Chair and Delegate McNamara, I think there is substantial evidence that video telemedicine is just as effective as in-person for many behavioral health treatments. There is less robust evidence on the effectiveness of audio only. Okay. That was kind of the conclusion of our research there, is that there is some promising evidence there, but there's just not been as much work done to look at the effectiveness, particularly comparing audio only to in-person or video treatments. A lot of what is out there is looking at the delivery of audio only services compared to receiving no services or as-is group. So we feel there needs to be some more academic research done there to look at that effectiveness, although it can be a useful tool. Thank you.
Mr. Chair,
Senator Tom,
just to
Senator Steve.
Delegate McNamara was correct. The House did discuss the reimbursement parity in the House version of the bill. As it passed the House, they they took reimbursement parity out of the bill. It remained in the Senate version of the bill.
Thank you. And so we spoke briefly here about the cost to individuals, and I'll just highlight again that the cost to individuals who do not have insurance coverage will vary pretty widely depending on the service they are receiving, the duration of that service, and the provider who is delivering it. When speaking with some providers, they gave us a range of about $142 to $341 per session. And I'll just make the point again that that is what they were charging, not necessarily what is being reimbursed if any of these services are currently covered. So finally, I'll spend just a few minutes discussing how coverage of audio-only telehealth would change if the proposed mandate was passed. We've touched on some of this a bit already. As you may know, insurance plans are already required to cover telemedicine services through the existing statute, but the definition of telemedicine services in code currently explicitly excludes audio-only services. That is where these bills would come into play, as the proposed mandate would amend that code to also require coverage of audio-only telehealth services, but only when no other means of two-way audio-visual communication is necessary, or is available. In other words, it could only be used if the patient could not access video services at that time. This slide provides some context on the current coverage of audio-only telehealth services. Following the end of the federal public health emergency, Medicare and many state Medicaid programs, including Virginia's, made some permanent changes to allow for continued coverage of some audio-only telehealth services for behavioral health. Virginia's Medicaid program currently covers all of those that are covered by Medicare, as well as some additional services. And the state's employee health insurance plans do not currently cover audio-only behavioral health services. This slide is just a reminder that health insurance mandates could apply to insurance plans covering up to 1/4 of Virginians. There's an exemption in the code for at least one of the plans listed on this slide, which I believe the Bureau will explain a bit more in their presentation. The remaining 3/4 of people are in plans like Medicaid and large self-insured plans, which are regulated at the federal level and not the state. So, Mr. Chairman, that concludes my prepared remarks. I'd be happy to answer any other questions you all may have.
Are there any questions for Dylan? Okay, thank you, sir.
Thank you.
Now we're going to get the lowdown from the Bureau of Insurance.
Mr. Chair, members of the Commission, I believe that we'll touch on some of the points that you all were asking about and get to at least what the results of our analysis showed about those cost differentials and what the impact would be there. So my name again, Brad Marsh from the Bureau of Insurance, Health Insurance Policy Advisor. We're going to look at HB 1918 as well as SB 1157 and audio-only telehealth coverage. Both these proposed mandates require coverage of audio-only telehealth services, and which we've discussed already a little about what those are. But the main difference between these two bills is that HB 19 does not establish a reimbursement payment standard for the audio-only telehealth, whereas SB 1157 would apply that same parity standard that is currently there for all other telemedicine, saying that it must be paid on par with an in-person visit there. So as you'll see a little bit later on, that does have a pretty drastic effect on what the fiscal impact would be of these, what the premium impact would be. We received carrier responses from 11 carriers, and which represented the below parts of the market there in that table. We queried them on their current utilization of telemedicine and audio-only telehealth specifically, and we asked them specifically just in those cases with these behavioral health interventions. So they're not reporting more broadly for physical health things, but just for what was actually identified in the bill as where the expansion of audio-only telehealth would occur. Since 2011, state-regulated carriers in Virginia have been required to provide telemedicine services and reimbursement at the same rate as a face-to-face visit. Audio-only telehealth is, or telephone is explicitly excluded from that definition. The analysis that we did here assumes that utilization of audio-only telehealth would increase, but only as access is expanded to individuals who currently don't have the coverage. Carriers indicated that 70 to 80% of their members already have coverage that includes audio-only telehealth in these situations when necessary. So for a behavioral health intervention where there is not an audiovisual method available to that member. So here we will look at House Bill 1918 and the impact of that on premium cost. HB 1918 is the bill that does not require payment on parity, that allows that audio-only telehealth visit to be paid at some other negotiated rate, not necessarily the same rate as face-to-face is paid. Based on the current costs for individuals with audio-only telehealth coverage, so taking sort of the utilization in those groups that are covered, the impact on premiums is looking to be about 2.7 to 2.8 cents per member per month of adding this audio-only coverage, but allowing it to be paid at a potentially lower rate. SB 1157, this is going to be the broader mandate that would have a substantially higher impact because of the fact that those audio-only claims would then have to be paid as if they were done in person. So if we look here at the first bullet here, the average carrier payment within the sample for audio-only telehealth was $19.29 per claim for audio-only telehealth. The average carrier payment for the comparable telemedicine there is closer to $100 there, $98.45. So in order to do this analysis, what we did was look at if we had taken the utilization of audio-only telehealth, and instead of paying it at this $19.29, paid it at the $98.45, and then on top of that, expanding that coverage to those additional 25 to 30% of folks who don't have the audio or who don't have any coverage for audio-only telehealth right now. So there'd be an expanded cost for those that are currently allowed to utilize it, and then there would be the full cost of actually covering those audio-only telehealth for those folks that don't currently have that coverage. And these next slides then just look basically at what the overall impact would be to the market of these two bills. HB 1918 that doesn't require parity would be about $128,000 for the individual market, $100,000 for the small group market, and $338,000 for the large group market. And on SB 1157, they jump up a little bit there with $471,000 for the individual market, $368,000 for the small group market, and $1.3 million for the large group market. Both of these bills, we do have these on two separate slides right now, but when we spoke with CMS about both of these bills, there was some concern on their end that the definition of audio-only telehealth within the bill was different than the definition of telemedicine there. And so when they see a definition that doesn't either reference the same point or have specifically the same language on it, they assume that there's a possibility that that's an expansion of the mandate.
Mr. Marsh, I think on one of the JLARC slides, there was an indication that there are 4 states that have this audio-only coverage. Is that correct? I wonder how these bills, either one would compare to what the law is in those 4 states.
And I think that, Mr. Chair, I think that would be a good thing to look into. I'm not sure exactly. We didn't look at exactly the language on those, and we had not checked to see. I don't believe any of those states are defraying for this right now. So, but in the end, that decision on whether something is in excess of VHB is a state decision that's made. So CMS will give us advisory information on this, but in the end, it's the state's job to identify things that are in excess of VHB. So every time we end our conversations with CMS, they make sure to let us know that in the end, it's our decision on this. But that their advice to us was that the current way that the bill is set up could be interpreted to include additional services that were not required because of the fact that the audio-only telehealth definition is different from telemedicine services. So the point being there that in order to avoid defrayal, this bill could be revised to specify that audio-only telehealth services are only expanded and covered only to the same extent as the telemedicine services, and that would be sure to then avoid the potential defrayal costs of their.
Mr. Chair. Just following up on the senator's earlier line, Senator Servel's earlier line of questioning, in either of these bills, does it anticipate that if you offer audio only, that you are required to also offer video services? In other words, like to stop you from going down the path of only audio services if you have Zoom and other capabilities available?
Mr. Chair, I believe that they would need to make telemedicine or the audiovisual available to an individual. I don't think that that necessarily a carrier would be able to direct somebody towards those audio-only telehealth if they desired to have the other. But I don't think that there's anything that would I think, necessarily take away from the existing services there or change the way that those services are covered. This is really supposed to be an expansion, and only in that very specific instance where a person does not have the capability of accessing those audiovisual services. And so you would need to document, or you could document that an individual, only had access to telephone and was in, a behavioral health crisis or some situation like that, where they needed to access a provider, but were not able to access those audiovisual for whatever reason.
Thank you, Mr. Chair.
So this next slide goes on to address basically the exact same issues within Senate Bill 1157. Really, the only difference between these two is that they pay on parity. So the difference is the impact here. All of the things that I've said about SB 19 or HB 1918 would apply here, in that there is the potential interpretation that the service include. That this would be an expansion of services. One thing that we wanted to note here, and we'll note again in the next slide, is that because of Section 382-6506A1 of the Code of Virginia, if it is determined, if the bill was not changed and was left in the current state with the current language in it, it would be in excess of VHB, and as a result would not apply to the QHPs. And the QHPs are going to be your individual market plans, as well as a very small percentage of about 0.5% of the small group plans out there that are considered to be QHPs. So if the bill were passed in its current form, the individual market would not be required to provide these audio-only telehealth services. It would not take away those services from those plans that are choosing to provide them, but the way that our law is set up right now, if something is determined to require defrayal, it does not get applied, and would only get applied if there's language in there that exempts it from the requirements of 382-6506, and money is put in to make those defrayal
So
costs.
this bill's either going to require an amendment, or it's going to require it to be reconciled with the other bill.
That's correct. Both of these bills were sent to HERC. So both formats there were 1918 and 1157 were separately sent by the separate chairs of Commerce and Labor in the two bodies. So we addressed them both. It's just that the language we tried to at least not give you two full presentations that looked exactly the same, but just look at where there was some differential between them. But yes, if either one, if passed in their current format, would not apply to the individual market, and would need, but if changed to reference the same thing on telemedicine, would then not require defrayal and would apply to all markets. And those options are here. In 1918, in its current form, it wouldn't apply to QHBs. It would not be subject to defrayal. One option that HERC would have would be to recommend it with those revisions, so that audio-only telehealth it would not be, an EHB would not be subject to defrayal. Or alternatively, if we wanted to keep it in the current format, you could recommend that it be passed with language exempting it from 38.2, but the money would then have to be there for the defrayal of the cost of this bill. And then the only real difference with here is you could amend this with Senate Bill 1157 so that it did not require defrayal like HB 1918 does. I guess it would be easier probably for the body to just recommend 1918 with those changes. But in the same situation here, if you wanted this to apply, you'd need to exempt it from 382-6506 in order to make it apply.
Okay, thank you. Are there any questions for Mr. Marsh? Okay, the bills are before us. Do we want more information on these before we make any sort of decision, or what's your pleasure? If we're going to take the bills up today, I want public input. Are public comment, or are you going to wait? Are we going to wait and try to get some more information? What do you want? Doug McNamara.
I think there seems to be some agreement that there's HB 1918 appears to be looked on more favorable by HERC, so I would suggest that we eliminate Senate Bill 1157.
Or conform it to
House Bill 1918. And given the time frame that we have, I think we ought to, if we're going to wait on insulin and the PSA testing, why don't we just do them all at the next meeting?
Okay.
My suggestion.
Is that the consensus viewpoint? Wait. Okay. Thank you very much,
Thank you,
Mr.
Mr. Chair.
Marsh. So the last bill we'll take up is House Bill 2206. I think there's JLARC report on that as well. Yes, ma'am.
Good morning, Mr. Vice Chair. Here are the slides. Good morning again. My name is Kimberly Sarte, and I'm an Associate Director at JLARC, and I will be presenting the findings from JLARC's review of the proposed mandate for proton radiation therapy. And as Dylan mentioned, JLARC reviews 3 primary questions as part of its Stage 2 reviews, which are listed on the slide here. This slide summarizes JLARC's findings at a high level. The proposed mandate would require health insurers to consider physician recommendation or governmental health coverage to be sufficient clinical evidence to justify coverage of proton radiation therapy. We found that proton therapy is a safe and effective treatment and is a generally accepted standard of care for certain types of cancer, but there's not yet sufficient evidence that it provides improved outcomes over conventional radiation treatment, which is often cheaper, for many common cancers. We also found that a small percentage of cancer patients are treated with proton therapy, which is only offered at 2 facilities in Virginia, and it can be a substantial cost to individuals without insurance coverage. Next, I will go over some brief background information. Proton radiation therapy is used to treat cancer, and projections show an increasing need for cancer treatment in Virginia in the future. An average of 41,000 new cancer cases are reported annually in Virginia, and the incidence rate of cancer is expected to increase due to an aging population. About half of all cancer patients receive radiation therapy of any kind as part of their treatment. So radiation therapy can be delivered through different modes, but is most often delivered via photon beam therapy. With photon beam therapy, high-energy X-rays are administered externally to the cancer site and travel through the body. If someone you know has had external beam radiation therapy, they have probably had photon beam therapy. The proposed mandate deals with proton beam radiation therapy, which is a different mode of radiation. Proton beam therapy is delivered by an external beam, but it delivers positively charged particles into a tumor. The main potential benefit of proton therapy stems from the fact that it can deliver a high radiation dose to a tumor with less exposure to normal tissue. Proton therapy has a minimal entry dose and little to no exit dose. With this therapy, the protons deliver most of the radiation dose to the tumor, after which the dose falls off to a negligible amount. In contrast, conventional photon-based radiation deposits radiation as it travels through the body and does not stop before exiting. And I will talk more about the evidence for the medical efficacy of proton therapy in a moment, but first I want to clarify what the proposed mandate would do, which is that it would essentially reduce the clinical evidence standard required for insurance coverage of proton radiation therapy. Existing code does prohibit insurers from denying coverage for proton therapy by using a higher standard of clinical evidence than for other types of radiation, and this was supported by a December 2023 Attorney General's opinion. However, HB 2206 would likely make it easier to obtain coverage for proton therapy by requiring that the clinical evidence standard for coverage be either that the treatment is covered by governmental health care coverage, like Medicare, or it is recommended by a patient's treating physician. So it would basically take away much of the discretion of insurers to determine coverage. We did look at where other states are in requiring coverage, and we found that at least 3 other states require some coverage of proton therapy. And I apologize, our slides, we tested them out at JLARC, but in this room, sometimes the text is going over the notes, so my apologies for that. Let's see. Mr. Chairman, as I mentioned, I will now talk more specifically about the medical efficacy and use of proton therapy. A key benefit of proton therapy is that it can target tumors that cannot be safely treated with conventional radiation therapy. It can effectively target tumors that require a high dose of radiation but are located close to critical structures like the optic nerve or spinal cord. It can also allow re-irradiation for patients that have already received the maximum lifetime dose of radiation to a nearby structure. However, by reducing the dose of radiation to healthy tissue, proton therapy can also potentially reduce the short and long-term side effects of radiation. For example, it can reduce developmental problems in pediatric cancers, and reduced radiation exposure likely decreases the risk of secondary cancers, according to medical experts and the research literature. However, evidence on the extent to which proton therapy improves outcomes varies across cancers. In practice, proton therapy is generally accepted as beneficial compared to conventional radiation for the cancers listed here. This list is based on our interviews with medical experts, a review of research literature, and insurance coverage guidelines. However, proton therapy still lacks sufficient clinical evidence of improved outcomes for many other cancers. For most cancers, proton therapy has similar effectiveness to conventional radiation in terms of cancer reduction. However, while research supports that it reduces side effects for some cancers like those on the previous slide, data from large randomized trials does not yet exist for many other cancers to conclude that it causes less side effects than conventional treatments, such as intensity modulated radiation therapy or IMRT, which would be the main alternative. Phase 3 randomized controlled trials are currently underway for a number of cancers that will provide additional data on the outcomes of proton therapy compared to conventional radiation, but those have not been completed yet. In terms of the availability of proton therapy, there are 2 centers in Virginia that currently offer this therapy, and these are Hampton University down in Tidewater and Inova up in Fairfax, and there are also a couple of centers in DC that offer it. In terms of its overall use, only a small percentage of cancer patients in Virginia receive proton therapy. To get a sense of utilization, we obtained data from the State Employee Health Plans and DMAS, both of which cover very large pools of individuals. So for the State Employee Health Plans, 15 members received proton therapy compared to 552 members who received IMRT over a 6-year period. In 2022, Medicaid covered proton therapy for 63 members compared to around 1,200 members who received more conventional IMRT. So conventional IMRT is provided much more frequently than proton therapy. We also asked Virginia's proton therapy centers directly how many patients they treat annually. Inova indicated that they provide about 300 new courses of proton therapy annually, which translates into about 300 new patients. And Hampton University declined to provide the utilization data to us. I will pause here, Mr. Vice Chair, if there are any questions.
Questions?
Mr. Chairman, I have a question.
Delegate Maldonado, then Senator Sir.
Thank you, Mr. Chair. Thank you very much for that. I'm curious, you mentioned the phase 3 studies in progress now, one of which includes prostate cancer, which we were talking about earlier today. Do you have a sense of when those phase 3 studies might be completed? First question.
Yes, I believe, I know based on our research, the phase 3 studies are expected to be completed anywhere between 2025 and 2031, and I don't recall exactly when the prostate is. Do you remember? Okay, and we believe the prostate one is supposed to be kind of in the near term of that time horizon.
Thank you. Follow up, Mr. Chair?
Delegate Maldonado.
Thank you, Mr. Chair. Do you have a sense for costs and usage, the data that you showed, whether it's the numbers are what they are, the difference between proton therapy and IMRT, if that might be because physicians aren't recommending proton as much, or the cost differential because the equipment is more costly and over time it has to be kind of amortized? If you have a sense of the context for those details.
Yes, so we will be providing, I'll be providing some out-of-pocket cost information in a moment. I guess the utilization, I'm sorry, which slide were you exactly referring to on the cost? I want to make sure I'm answering.
Mr. Chair. Yeah. Thank you. I was just curious. My understanding is to construct these facilities is quite costly.
Yes.
And that is maybe adding to why the treatment is more expensive, but I imagine that over time, as they recoup their costs, that it might come more in line. So I was just wondering if you want to get to that part later when you talk about the financial piece of it. That's perfectly
Sure, no,
fine.
I understand your question more directly now. Yes, one thing we did here in our research is that the machines themselves are definitely more costly. So a conventional IMRT machine may be like several $1 million, whereas a proton therapy machine may be tens of millions of dollars. So it definitely is a more costly technology to provide.
Thank you.
Senator Servo.
Mr. Chairman, I had a couple of questions. First of all, I have I'm constantly triggered every time we talk about proton therapy because Delegate Mamie Bacote used to put in a budget amendment every single year 15 years ago trying to get the Proton Center down in Hampton funded because of the things you're talking about, its effectiveness. And I guess now Inova has built one in Fairfax, and I would suspect that, is it fair to say that part of the reason that the cost might be as high as it is because there's not really a lot of competition in the market for this particular type of service at this point in time?
Perhaps. I think what I would go back to is what we heard most directly is just that the cost of the technology at this time is more expensive.
Okay. Further question, Mr. Chair.
Senator Servo.
I don't think there's a lot of these around the country even, right? But if you had some sense of how many there were around the country, that'd be nice to know. But the second, and I kind of suspect that part of the reason that the states that you have listed have mandated or required to provide is because they have one of those facilities in their state. And there might be some political reason behind that. But so if you can answer that question about other states, it'd be useful. The second thing is when I think you said this is currently covered by Medicaid or Medicare, and perhaps even by veterans health care. You didn't say that, but I would be curious about that. But I would just be curious with regard to the government insurances that are covering it. Do they limit the coverage to the types of cancers that you talked about where it's shown to be most effective, or do they offer it for anything that a doctor wants to try to use it for?
Yes, good question, Senator. I think to answer your first question, I believe we heard there were around 50 centers nationally. Does that sound about right? We can, if that's off, we'll follow up with you. But I think I remember in looking through the information, there are about 50 centers nationally. In terms of coverage, so Medicare provides probably the most robust coverage in terms of what they typically cover, and they typically cover the types of things that I mentioned on that slide, like ocular tumors, base of skull tumors, head and neck tumors, and Medicaid does as well, but they do provide it more on a case-by-case basis. So they kind of have a process they go through to determine, Medicaid in particular, I believe, on whether or not, I don't think they have blanket coverage for certain types of cancers.
Mr. Chairman, one last question.
Senator Servo.
I haven't really done the comparison, but isn't it kind of unusual that you might get more robust coverage under Medicare or Medicaid than you would through private insurance, or am I imagining things? And you might not even know the answer to that question.
Yeah, I feel that's not
Insurance,
something that we
maybe,
looked into. I think my understanding, just on my general work, is that Medicaid coverage, at least what we've looked at, can be fairly comprehensive. But yeah.
Okay.
I think it very much varies depending on what specifically you're looking at.
All right.
Delegate McNamara.
Thank you, Mr. Chairman. I just wanted to share a little bit of the background from when we heard this bill in committee about a year ago, a little better than a year ago. And I think the question and the reason that I wish Delegate Sullivan was here, because I recall one of the reasons why we sent this bill to HERC was there's certainly no question that some of the proton therapy has been proven to be very effective, and private insurers are covering it for certain things, pediatrics in particular, ocular is another one. But the way the bill reads, it says, really, it opens up to any coverage whatsoever. And that was the big concern on a cost perspective. So even in areas where it's not more effective, but is certainly quite a bit more expensive, we'd be creating a lot of liability. I haven't seen from your background that we also had concerns. The concern at the time was it's not more effective, but it's certainly quite a bit more expensive. And your presentation suggested that at least between that time and this time, 15, 18 months, there's nothing to suggest that that data has changed, that there's sufficient data out there. So I almost think that one of the reasons we sent it for further review was to try to determine if there is additional benefit, and it appears there's not additional benefit. So I'm wondering if we should be moving down this road any further.
And that is your conclusion, that this is no more effective than photon.
So the two ways to kind of look at it is the effectiveness in treating the cancer and then the side effects. Based on our research and based on our conversations with medical experts, in terms of effectively treating the cancer tumor, proton and IMRT are typically, I'm not a doctor obviously, but are typically similarly effective. So it's really the side effects. And I think that's where there is some research to show pediatric cancers where, yes, you definitely want to limit the dose to like bones because it can really cause problems down the road. Theoretically, you would expect it to reduce the side effects, but that has not, those clinical trials have not completed. So the way the clinicians have described it to us is for a lot of these cancers, the reduced dosage, it's not clear whether it's clinically relevant, that it makes a difference in the long-term outcomes. That research has not come to full fruition yet. It sounds like over the course of the next few years, it may, but those trials are still underway. So it's really the side effects that you're looking at, and then whether the increased cost is worth it.
Thank you, Mr. Chair. Thank you for touching upon that very issue, because when I would love for us to sort of consider when we think about the cost, not just looking at the numbers, because there is a human component around the side effects and the experience going through treatment. And while the answer about the long term, is it the same as IMRT or not? What we have seen anecdotally is that patients who experience this actually experience fewer side effects and feel better and have shorter terms, treatment terms. So I just sort of want to reiterate that when we think about the numbers, I don't want us to just think about the dollars. I believe it will work itself out over time as the equipment gets paid for, but there is a high cost. And anybody who knows anybody who has gone through traditional radiation or chemotherapy knows what they experience and what those side effects are. And they are seemingly different and abbreviated and not as intense with this type of treatment. Thank you.
Mr. Chair. Thank you, Mr. Chairman. Just kind of following up to Senator Surville as well, early on mentioning Senator Baycoat bringing this back several times in the past. And I think early on, as those bills were introduced, there was so little information or data around the treatments. And I think versus today, if we, did I hear you say that Hampton did not provide data surrounding it?
Right. We did request data on utilization and cost, out-of-pocket costs from them, and they did not provide it. We requested the data several times from them and just never got a response.
Yeah, I think just experiencing some of the constituents from Hampton Roads and what's been relayed, I think, to many of our officers there is that there actually is an increased demand for these services when it comes to proton therapy, and people are coming even from out of state getting the treatments and paying out of pocket. And so, and the end result, as I understand it, is being effective in those treatments, and then the side effects being minimized is what has been reported to me and many others in Hampton Roads. Fast forwarding to some of the information that you provided to us today is that the treatments are effective and safe, is what I heard. And contrasting that with what we knew back when Senator Baycoat was actually trying to sound the alarm, so to speak, to find that we're in a place today where it's much more data and it is being proven to be safe and effective, limiting the negative effects to some of the outerlying healthy tissues, then I think it's something that we should be considering, is what my recommendation is.
Thank you, Delegate Hayes. Yes, ma'am.
Like me to continue? I'm almost done. So next I will turn to the cost of proton therapy for individuals without insurance coverage. So the cost of proton therapy is substantial and is typically higher than the cost of conventional photon therapy. As I mentioned, we requested comprehensive treatment cost estimates from both Hampton University and Inova, but they declined to provide us this comprehensive cost information. The cost will vary, of course, depending on the type and complexity of the cancer and the number of sessions required. But as an illustrative estimate of the out-of-pocket cost of a typical course of 30 treatments, and this is based on Innova's published discounted charge, the cost would be from about $75,000 to $96,000. And this would be just for the delivery of the proton therapy, not any related treatments or services. Both Inova and Hampton do have financial assistance programs for patients who qualify, which are largely based on financial need. And then again, moving to the coverage that would be required by the proposed mandate. Insurance plans typically offer some coverage of proton therapy, and the code prohibits health plans from holding proton therapy to a higher standard of clinical evidence than other types of radiation. Medicare, Medicaid, and the same employee health plans and private insurers all offer varying levels of coverage, with, as I mentioned, Medicare typically covering a greater range of cancers. However, for many cancers, coverage decisions are on a case-by-case basis. And as I mentioned previously, the proposed mandate would likely lower the standard of clinical evidence for coverage by requiring that a physician's recommendation or governmental health plan coverage be sufficient to meet the standard of evidence for coverage. So in practice, this would likely require insurers to expand the cancers for which they cover proton therapy. And again, this is just a reminder, as Dylan mentioned, that health insurance mandates only apply to up to about a quarter of Virginians. Mr. Chairman, that concludes my presentation, and the team and I are available for any other questions that members may have.
Are there any additional questions for Jay Lark? Okay, thank you very much, Kimber. Thanks. Now, Mr. Marshall is going to give a slowdown.
No, we're still in the old presentation.
So many people were on the ledge anyway.
Should have made these into individual presentations for y'all. That might have been easier. Perfect. Thank you. Mr. Chair, members of the Commission, I'll present on BOI's analysis of HB 2206. I'll try to skip over anything where I'm touching again on things that Jay Lark has already done in the interest of time. HB 2206 is a mandate for coverage of proton radiation therapy and does require coverage or require to be considered as clinical evidence the fact that the coverage is covered by Medicare, Medicaid, and or that it was recommended by patient's treating physician. BOI queried carriers on the current requests and utilization of proton radiation therapy, as well as the cost of the approved claims for these services. We additionally asked each of the carriers to provide us some analysis of the savings that they currently get from using either photon treatment or some other treatment to the proton radiation therapy. We did not get any responses from the carriers on that, so we're not able to look at what potentially they think that the increased cost could be of folks who are currently using these other approved therapies. In current coverage in Virginia, carriers did indicate, as Jay Lark said before, that they do cover proton radiation therapy for the treatment of some from some cancers, but they do look at the appropriateness of that treatment for that cancer and for that specific situation. HB 987 was enacted last session as Chapter 538, and it does permit carriers to consider those factors, but does not require them to consider that to be sufficient evidence for coverage of proton radiation therapy. For the purpose of this analysis, the utilization of proton radiation therapy is expected to increase only as requests for this treatment that were formerly denied would now be approved. That does not necessarily mean that there doesn't exist a desire for utilization of these services, but we can only really address what we saw in denials for these services within what's actually gone to the carrier. So there is the potential that that there would be more requests for this out there if folks knew that these services were going to be provided, but we didn't have any evidence with which to do an analysis of what the effect of that would be. So changing the proton radiation therapy coverage as required by HB 2206 could result in increased cost to carriers, as those carriers would be required to pay for those claims that are currently being denied under current coverage. We did assume that they would be that those claims would be covered because they were requested by a physician in order for them to be a claim in the first place. Those were requested, and that would then meet that standard that's put in front of the bill that for coverage of it. So if your physician recommends it, then it's covered essentially under the way the bill is designed there. So applying the average allowed cost per approved claim to the denials for this service resulted in an expected impact on premiums of around 5.5 cents per member per month. We did work with the allowed cost because the incurred cost that we saw was substantially lower than the allowed cost, and also substantially lower than what we had seen in literature to what you would expect to see folks paying for this. And so we wanted to look at least that high end of the potential cost of this and look at those allowed costs there. This mandate is expected to increase overall healthcare costs as these claims that were denied in a prior situation would be approved. Based on carrier reporting, the cost of this mandate are estimated to be about $250,000 for the individual market, $195,000 for the small group market, and $659,000 for the large group market. Because this is considered to be a mandate, and in addition to EHB, the QHPs would not be required to provide these benefits if the bill stayed in its current format, so they would not be imposed then on the individual market and that small portion of the small group market there. But since that mandate would not be imposed on QHPs, there would not be any defrayal that would be required. The options on this bill would be to recommend HB 2206 in the current form, which would not apply to QHPs and would not be subject to defrayal. The bill could have some other fiscal impacts, but it would not have that particular defrayal impact there. You all could recommend that HB 2206 be passed with language that exempts the mandate from 382-6506, and that would make it apply to the individual market, but you would then have to pay for those defrayal costs for the QHPs that would then be required to cover it. And in addition, this bill could be recommended to be included as part of the current EHB benchmark review. So it could be sent over to that process. We would do a little more analysis on it there, and then it would be presented as a part of that report that we'll present to you all before March of next year of the mandates to be considered. And you all would look at those costs and what was talked about before, that actuarial richness and whether, which bills you might want to try and put in there. But this bill would be appropriate potentially for inclusion in that and adding into the EHB benchmarks.
Okay, I think Senator Serval has a question.
So Mr. Chairman, here's my question. I went back to the first slide, Mr. Marsh, which says that proposed mandate requires a health carrier considers as a sufficient standard clinical evidence to justify coverage of proton therapy, either the fact that it's covered by Medicare, Medicaid, or whatever. It doesn't say that anybody's exempted. I mean, who are we covering if we're not making it a mandate on those plans or
on the Mr. Chair, Senator Serval, on the qualified health plans? You would still be applying it to the large group market and about 99.5% of the small group market. It would really just be the individual market that would be exempted from from that coverage.
What about the state employee plan?
The state employee plan would have to provide those services per a different. That's a different requirement under law. But yes, if the state makes a mandate, the requirement I believe under law is that the state employee health plan has to cover those services.
So there might not be defrayal, but there would be a budget impact.
Potentially, yes, and I think that was what I was alluding to in the slide where I said there may be other costs there. There wouldn't be that particular defrayal cost, but there could be those costs of applying it to the state employee health plan.
Okay.
Is that your question?
Mr. Chairman, that's one other question.
Okay, Senator Servo.
Have we ever passed another type of, through this commission that you're aware of, or I guess the legislature since 2012, of some kind of a mandated benefit that does not apply to the individual market to get around the defrayal requirement? Because I mean, it just seems to me that'd be a pretty hot trend if that was something we did regularly.
Mr. Chair, we did that with the prosthetics bill from a few years ago, from I think 2 years ago. And so for a 1 year period there, it was exempted from being applied to the individual health plan. We then included it in the state then included it in the request for the change of the benchmark plan. So it became a benchmark there. And then it was, I think the bill was set up with language that basically sunset the requirement on the QHP or the requirements on that prior to next year when that EHB benchmark would go into effect. So there was a period of time where we exempted a bill so that we did not have to defray. There was, however, a plan to move that in to have coverage for everyone there. So it's been done before.
That's not what this bill proposes, though, right?
Not currently, no.
Right, okay.
Senator.
Delegate Helmer.
Yeah, thank you, Mr. Chair. Mr. Chair, for the BOI, just do we have a sense of if we did that first component, the covered components by Medicare, Medicaid, or government health care coverage, as opposed to the clinical prescription for it? Do we have a sense of what the difference in the cost would be of that versus the whole of it?
Mr. Chair, Delegate Helmer, the way that the bill is phrased right now, and I don't want to get into a situation of making a legal argument on this, but it says that the fact that it is covered, not for a particular type of cancer, just the fact that it is covered by Medicare, Medicaid, or any other governmental health coverage, it is, as JLARC presented, covered by Medicare, Medicaid, or any other governmental health coverage. I mean,
Mr. Chair, this is an and. These are and bullets, not or.
No, it's either. Delegate Helmer, it is or, and or within the second bullet.
Quick follow-up. So, yeah, my question is from a cost standpoint. The first bullet there is substantially. When JLARC made their presentation, they said there's a number of evidence-based uses of proton therapy that do have good, sound scientific basis for using them. I imagine, although I don't know, that the Medicare, Medicaid, government health care coverage is tied to those that have substantial clinical indications to them. And I was just asking, do we know what the cost would be if we just took on those specific diagnoses that have good clinical evidence behind them?
Mr. Chair, Delegate Helmer, I did just want to note that is not how the bill reads right now. So if you took that out, it would be a different bill there. But if the idea would be the fact that proton radiation therapy coverage is covered for this type of service or some sort of language like that in the manner that Medicare, Medicaid, we did not look at that, at what that impact would be. And but I'm trying to think of how we might be. We could look into potentially doing an analysis of that if a different bill was to come up.
Are there other questions? Okay. Have you completed, Mr. Marsh?
Thank you, Mr. Chair. That's the end of our presentations on these bills.
Is there further discussion, or what's your pleasure on this bill? Okay. Try to get some more information. Welcome to the HERC. Yeah, welcome to the HERC.
Mr. Chair, I do think it very specifically would make sense on that one to understand. It sounds like this bill is very, very broad and perhaps a more narrowly tailored look, at least to understand before we made a recommendation what would happen if we more narrowly tailored it might be helpful
from my standpoint. I think it's worth figuring out the effect the reduction of side effects this has on certain cancers. I think could make it a unique sort of treatment that that deserves some consideration.
Hey, Mr. Chairman.
Senator Servo.
Right. I think I agree with Delegate Helmer that as written, is very broad, but there's probably some standards we could build into language to where we could mandate a lower review standard if certain requirements are met, such as a positive review from a phase 3 clinical study that Delegate Maldonado was mentioning. I mean, I had people, texting me in the middle of this, for example, that said, in addition to the things that Ms. Sart mentioned, this is an effective treatment for left-sided breast cancer because of the proximity of the heart. Whereas if you're trying to hit that with a photon, you're going right through the heart, which is something you typically try to avoid. And so, I mean, there's other specific scenarios, I think, that it could help also. And I have a friend whose wife runs one of these centers in Seattle, and he's been preaching to me the benefits of this for a decade. So, I mean, I understand the value in it. But the reimbursement thing's a whole different issue, and we just need to have some guardrails on it.
Then we will put this off, and thus the SAG. I don't think I need to repeat that. We're down to number 7 on the agenda, the discussion of legislation referred to the commission during the 2024 session, and we're going to receive a presentation from the Bureau of Insurance on that. The next meeting. We're going to, and there will be a next meeting, I promise you.
All right, there we go.
Senator, our Delegate Sullivan, you're listening to me online, I assume. There will be at least one more meeting and probably 2 more before the end of the year on this. I trust that I'm correct. No response. Mr. Shipman.
All right. Very good. Good afternoon. My name is Garth Shipman. I'm with the Policy Advisor with the Bureau of Insurance. Here today looking at the Step 1s that you saw reference to earlier today. In a Step 1 assessment, the BOI summarizes the bill. They determine the extent to which the proposed mandate is currently available under qualified health plans in Virginia, and also whether the proposed mandate, how do you advance? Just next slide. Yeah. So whether the proposed mandate exceeds the scope of the current essential health plan benefit benchmark plan. We're going to skip the next slide in the interest of time. We're going to discuss House Bill 946 and Senate Bill 736, or 376, I'm sorry. And this proposed mandate would require carriers offering plans to ensure that 50% of their plans conform to specified cost-sharing limits and prescription plans. For example, the limits will be varied based on the type of plan. So your gold, silver, and platinum plans may limit the cost sharing to $100 per 30-day supply. Your bronze will limit that cost sharing amount to $150 per 30-day supply. Plans that meeting these requirements under the bill must be clearly labeled and marketed alongside other plans. Next slide. So as part of the Step 1 assessment, BOI conducted a survey of the carriers and responses and indicated there are no plans offering a limit on cost-sharing payments for prescription drugs as required in the bill. Prescriptions are typically in different tiers within a plan, and carriers indicated that while some lower tiers conform or below the cost-sharing limit, that's not true for all the tiers within a given plan. There were 8 carriers responding, and which represent 95% of the market in Virginia. So next slide. So mandating the legislation requires that you mandate the limit cost sharing for 50% of the plans offered by a carrier, and that is not contained in the Virginia EHB benchmark plan. So the BUI would not characterize the mandate contained in 946 and SB 376 as a new essential health benefit and does not anticipate that there would be a defrayal cost if the mandate were enacted. As you can see, CMS has previously indicated to the department that the cost-sharing mandate shouldn't be part of EHB benchmark plan. Next slide, please. So here's the options for HERC at this point. There are typically three options given it deals with cost-sharing mandates. The second option really isn't on the table. So option number one would be recommend bills for step 2 assessment for BOI and JLARC, or step 2, or your other option would be take no action.
Okay, on these bills where we're looking for the recommendation for step 2 assessment or to just let the bill die, what's your preference there? To wait till the end or to do it all at once? Or do it one at a time?
Mr. Chair, do we know what the capacity, like, can they do, if we just said, hey, move these all through, could they do, that just affects whether we wait one at a time or?
You can skip to page 14.
Well, I mean, that's a good question. What sort of capacity, if all these bills we sent for a second level analysis, is it something we could anticipate you could handle?
Mr. Vice Chair, Rebecca Allen again for the Bureau of Insurance. So if whichever bills that HERC decides to move along, BOI stands ready to go ahead and evaluate those, but that's our specific capacity. You'd have to ask JLARC about theirs.
Happy to speak for JLARC. Thank you, Mr. Vice Chair, for asking. So I talked with Hal Greer, our director. We feel we can probably do 1 or 2 more step 2s this year with our others. As many of you know, our big load of studies is in the fall, so a lot of our staff is tied up. The other thing I would mention is that we typically don't do the cost-sharing bills, and that's because the value we really add in our assessments is the medical efficacy, the utilization, and the out-of-pocket cost if there's if somebody doesn't have any insurance coverage. So I guess you wouldn't have to consider us in any cost-sharing bills because we don't typically have not looked at those in the past.
Why don't we wait till the end if we've got one or two of the non-cost-sharing bills you can handle? Let's wait till the end to hear all these bills and then we'll see.
All right, very good. Let's move on to. Oh. What's that?
So we have 24 months.
So just to clarify, JLARC could do 1 to 2 more this year if you needed it before the session, but by December we could do probably a couple more depending on how in depth they are. But yes, with the greater time frame, we can obviously do more because we can sequence them.
All right, let's move on to expedited assessments. Next slide. BOI's received requests for expedited step 2 assessments for 3 bills. And they're listed there. House Bill 230, cost sharing for diagnostic supplemental breast exams. House Bill 513, dealing with mandating coverage for PANDAS and PANS. And House Bill 760 deals with insulin and diabetes equipment cost sharing payments. If HERC does request that BOI conduct an expedited step 2 assessment, meaning there's no official step 1, you will still probably get the same information. Similar step 1 information will be in the step 2. That won't be left behind as far as that. So move on to the.
I apologize. I don't know whether my question's for you or Tom. Senate Bill or House Bill 760. How is that different from the bill we just considered that would? This is equipment, not insulin. Okay. Thank you. Delegate Helmer answered my questions about that. So we've got 3 requests for expedited review, and just one request, I guess, for a step one assessment, 946,376.
Correct.
Mr. Chair,
And 499, I guess.
Mr. Chair, based on this and their statement, I wonder if it would be appropriate for me to move for these to all go to the step one review.
Okay. Delegate Helmer's moved for all these.
For step two review, Mr. Chair.
Has moved for all these bills to go to step two review.
Okay.
Okay. Which one? 230, 513, and 760. Is there a second to that?
Second.
Okay, is there any further discussion? All in favor of that motion, please say aye. Aye. Any opposed? Okay, those bills will all go to step two review.
Thank you. And that concludes the presentation.
Mr. Chair, just a note, there were other bills referred to the commission this year. I just believe the Bureau is still conducting their step one. They've reached out to the providers and just hadn't gotten all the data yet, and that's why we haven't gone over those today.
Okay, is there further discussion?
Mr. Chairman.
Senator Surville.
Yeah, I just want to say, I've been on this commission now for, I guess, 4 years, and I just want to note for the folks who are new, what you just experienced today is what I've been experiencing for the last 4 years. We get a lot of very complicated, very technical stuff presented to us that often doesn't fit into the normal lenses through which we evaluate legislation. And we often have a really hard time trying to figure out a way to think about these things or set a consistent policy. And I think it's really important that folks review the packets and the materials that we get ahead of time and try and think about these things ahead, because we often just get sort of paralyzed by the volume and amount of information that gets thrown at us at these meetings. And we have a lot of potential to do a lot of good here, but this is very complicated stuff, as I think everybody's just experienced. And so I'm optimistic we can get something done, but I think we just put ourselves in a position where we now have to consider 8 bills for substantive action at our next meeting, I think, or our next 2 meetings. Plus, I guess there's some other bills that got referred to us that we'll see what happens with those. But, when we don't act, things can pile up. So that's why we didn't act on 27 bills in the last session, I think it was.
And even though even though Delegate Sullivan did not speak when I asked the question, he texted me that we will meet at least once more, maybe twice more, before the end of the year.
Point of clarification.
Analysis, step 2 of those cost sharing bills.
Yeah.
You want to include that in a motion, or?
Yeah.
Senate Bill 376.
Senator Surville's made the motion. Delegate Helmer seconded. All in favor, say aye. Aye. Opposed? Okay, those bills are considered for step 2 assessment. Okay. We are down to the public comment section. Are there those in the public who would like to speak? Hearing none, we are adjourned.
Senate of Virginia, Richmond, Virginia.